Thank you very much, Dr. Kaustubh, Dr. Pareen, and Dr. Jamin for allowing me to share the podium. Basically, uh, Dr. Cherian nicely responded to Dr. Apinder. It's all about choosing the proper surgical approach in case of cellular supracellular tumor. So, a lot of many controversies around. So, previous discussion was for giant pituitary adenoma. So, the basically area is cellular supracellular. Now, my talk is basically on craniopharyngioma. The area is cellular supracellular, again the same. But still, we have to be very skeptical in choosing the surgical approach, because your surgical approach will decide the post-operative outcome and hence will definitely influence on the morbidity and mortality. The growth in case of pituitary adenoma will be from below to down, below to up, whereas in case of craniopharyngioma, most of the time 90% cases from above to below. It's important to know in bits and pieces about embryology, because it will guide you about give you some idea about neuroimaging preoperatively, so that you can decide your surgical corridor. As I said, it's a benign, but location makes it offers its behavior as a biological malignant. More than 90% location is supracellular. Let me tell you, the incidence of pituitary adenoma is more than 10 to 15% around 100 cranial tumors, whereas incidence of craniopharyngioma is 1 to 4% nearly out of 100 brain tumors. So it is less, but it happens in pediatric age group as well. It happens in the geriatric age group as well in the middle age group as well. So the controversy runs around choosing the approach in endoscopy, whether transcranial, endoscopic, transcranial, endoscopic, transventricular, and different age group. So the best answer is individualization. I'll come to that. It arises from the Rathia spouse or craniopharyngeal duct. See, these are the figures. These are important vital structures in the supracellular areas, basically. Hypothalamus, optic chiasma, floor of the third ventricle. Tumors attached with this, in this proximity of these structures, should be left alone. After spending 1 or 2 or 3 decades, probably a surgeon starts controlling so-called, I should not use that word, ego, that I should stop here. Psychistically, sometimes we use it's a pulling game. No, it's not a pulling game. Holding yourself, holding your temptation in the proximity to the vital structures which offer you, will save patients from post-operative endocrine deficit and hypothalamic disturbances. And ACP stands for adventinomatous craniopharyngioma, and PCP stands for papillary. Adventinomatous more commonly seen in pediatric age group, and it follows the rule of 90% calcification, 90% supracellular growth. Papillary, it's seen in the middle age group as well. These are some of the histological slides. It follows the keratinized pattern, whereas it follows the squamous epithelial pattern. Now the presentation, it varies according to the age group. These are 4 common modalities of presentation: endocrine, ophthalmic, raised intracranial pressure, and uncommonly motor deficit. It's very important to evaluate the patients preoperatively. Why? Because you can correct the hypoadrenalism by the IV steroids rapidly, but no, in case of subtle or prominent hypothyroidism, you should take some time, you should give some time. Now, children more often present with the raised intracranial pressure signs, hydrocephalus, whereas more calcification is more common. Whereas in adult, it is more of the endocrine deficit and visual symptoms. Fine. As I said, hypoadrenaline should be corrected with IV steroids. Poor endocrinological profile preoperatively has poor comorbid outcome postoperatively. That's a dictum. Take the help of navigation before you choose your approach preoperatively, if it is possible for you. Now, the goals of treatment: maximum safe resection to decrease intracranial pressure to improve vision, and cure if not possible, then preserve good neurological status. A sweet neurological book, as first chapter it mentions, do not harm the patients. If you can't cure, just stop that moment. Don't disturb the vital structures as much to make the patients comorbid postoperatively. Now, choice of treatment, it's maximum safe resection, IMRT, as Dr. Kinjal has addressed. Intracystic therapy, that's the Toronto protocol by interferon. Previously, bleomycin was used. Now it is no more used because of the neurotoxicity into the subarachnoid species. Now the most controversial are 3 things: surgical approach, choosing the surgical approach, extent of resection, role of adjuvant therapy. Surgical approach, you should have good knowledge of neuroimaging. Now, choice of approach, no common consensus. No final chapter has been written that this approach is best for this growth, this and this growth. No. Individualization. Individual is something, surgeon decides his own approaches based on his own personal experience over the period of decades. And believe me, it cannot be sustained over a period of night, in weeks or days or months. It's a long process. Properly selected approach has good outcome. Retrochiasmatic, pediatric, and recurrent tumor. These are main three challenges. Retrochiasmatic, which approach to be chosen? If I would ask some retrochiasmatic tumor, probably 10 out of 10 neurosurgeons, 5 out of 10 neurosurgeons would say different, and 5 out of 10 neurosurgeons may say different. And actually, 10 out of 10 may be right. So, approach should depend on size and extension, location, cellular, paracellular, supracellular, intraventricular, tumor consistency and calcification pre-op CT scan should be done in case of doubt, so that you can change your approach. And proximity has to be discussed with your team before approaching the tumor. Now, neuroimaging compression versus invasion may not be apparent. Poor tumor hypothalamus interface. Now, these are some example. Pre-infundibular approach in case of different. Post-infundibular approach is different. Trans-infundibular approach is different. So everywhere, I said individualization is the best answer. Choice of approach, cellular, purely cellular located craniopharyngioma per se less common as compared to supracellular variety, because 90% is supracellular growth. Intraventricular, it's transcranial, intraventricular, microscopic, be it endoscopic, supracellular, greater degree of individualization is seen in there. Now, choice of approach for endoscopic is purely infrared diagnostic for cellular and for extraarticular tumor. You can address them. The problem in pediatric age group in endonasal approach, they have small nostrils. Pneumodigestion, they finish by the age of 10 to 12. So again, one more problem, blood loss. Proper set of instruments need to be seen. Sometimes you can't use two suction techniques, not all the time. Availability of vascularized flap for reconstruction. Transperineal approach, predominantly cystic with limited supracellular extension and supine with the head in sniffing position. It's a 15-degree lateral to the opposite side. So you can address both the nostrils simultaneously. Some of the Indian surgeons, they are fine with the supine position. It's okay. This was mentioned in the Theodore Swartz book. Extended approach, extension above the diaphragm sala, needs removal of the bone above the tuberculum sala. Wide exposure is sinus is required. Tumor decompression allows visualization of all vital structures. Preservation of stock whenever possible. Please try to preserve. It offers significant endocrine deficit and severe dyselectrolysis, may lead to intractable seizure in most of the patients. CSF leak, you can use reconstruction technique, as Dr. Apinder said, one of the 4 variants, apart from lumbar CSF drainage as additional tool. Now, supracellular approach for extraventricular, it can be, you can use endoscopic approach, transventricular, supraorbital approach as well. Supraorbital should be kept restricted to few tumors. Open or transcranial approach, that is pterional, which is more commonly used. Unilateral, that's you can go for bifrontal. Each indication has different, it applies on basis of your expertise. You cannot choose the approach. You should choose the approach according to the growth of the tumor in particular direction. Endoscopic transventricular approach, it has access via lateral ventricle, often through the foramen of Monro. Cyst foundation and catheter placement can be done, where you can offer the intracystic therapy as well. Less brain retraction, fornix handling is a problem. Try to preserve its fibers to avoid the memory disturbances post-operatively. Pterional, most versatile, commonly used. Make sure you drill the sphenoids properly. It will give you proper corridor. Prechiasmatic space. There are 3 spaces between the optic nerve chiasma and cellular tubercle, optico-carotid triangle, and lateral corridor. That's the lateral to the carotid artery. Bifrontal craniotomy, as it was shown in case of olfactory groove meningioma, allows visualization of optic nerve and chiasma, supracellular region, third ventricle via laminar terminalysis. Advantage is excellent midline exposure and useful in post-fixed chiasma. Remember, there is difference between post-fixed chiasma tumor and retrochiasmatic tumor. Retrochiasmatic tumor may not be post-fixed chiasma. You must know the differences in the MRI itself. Intraventricular and combined tumor, you can go for transparental approach or interhemispheric approach. Surgical corridors in intraventricular approach, there we can enter through the foramen Monro with subacrotal dissection. The best advantage for this case is you can see the tumor wall and hypothalamic interface, so that you can avoid the injury to the hypothalamus, which is for which there is no particular test available post-operatively until patient does not show the improvement in consciousness, throws intractable seizure and constantly fever. So should be avoided. If you're like we say in Hindi, gadaya par sher chala gaya. That's not the goal of our surgery. Translaminar terminalis approach as well. Limitation is posterior third ventricle access is difficult in this case. Now, tumor dissection technique. Tumor decompression first, piecemeal removal of the tumor. Cyst should be addressed first. Calcification, if in the proximity of optic chiasma, hypothalamus or carotid artery, should not be disturbed too much. Because by removing calcification, you are not offering any rocket science cure to the patient. If possible, please go for the excision of the calcification spots, but they are in the proximity of vital structures, do not disturb them. Check proximity and be careful while handling the stock. Key points: pediatric, recurrent, retrochiasmatic. These are three very challenging craniopharyngioma. No single approach is best for all. Individualization is best. Maximum safe resection has to be the goal. And preserve white structures is a carry messages. Intracystic therapy, lot has been said about this and that. Bleomycin obsolete now. Interferon available. Some of the people use it. They put the OMA or EVD catheter into the cyst, but make sure you aspirate some of the CSF first, and then you instill it, and followed by 1 ml of normal saline into the cavity. It should not go into the subarachnoid space. Please make sure. These are some of the post-op assessment: hypothalamic, endocrine disturbances, intractable diabetes insipidus, dyselectrolemia, bleeding, hydrocephalus can be managed with the shunt CSF diversion. Complication. These are the list of complications that is seen in the largest study. Now, this was our scenario. Endoscopically addressed cellular pathology purely. So craniopharyngioma we addressed 9%, probably less than 5%. And we lost one patient post-operatively. There was a thin fiber-like part of the capsule. After the completion of surgery, everything was fine, and we are done with our objectives and goals. And we tried to pull it with the disc forceps, models of disc forceps. It led to oozing. Immediate post-op scan showed intraventricular hemorrhage, lateral ventricle, third ventricle. We did everything, EVD insertion and this and that, but that was damage to the third ventricle floor. Patient could not be survived. 22-year-old young lady. So it must be of our significance. So it requires basically honesty, endoscopic approach. Before that, you need to be thorough with the neuroimaging so that you can decide the approach. It takes years, decades to learn the proper approach and to master as a technique. These are some of the WFNS trials based on the surgeries done by young guys and the senior guys. This requires specific attention. As you get the masterize the technique, your graph shows down because you try to attempt the maximum growth resection, and in trying to do so, you offer more morbidity or mortality. So the interpretation has to be very careful. If you draw your graph, you might think I'm going down. No, that may not be the case. So evolution takes time. This is a feature of picture of famous neurosurgeon Harvey Cushing. It takes years. If something goes post-operatively in such case of tumor, then you must be honest enough in front of the mirror at least that something must have happened in case of hypothalamic failure or severe endocrine deficit. Something must have happened because of my significance. So honesty in front of the mirror is very important in such cases. Then only you can learn, you can transform yourself. Real honesty is required. That's it. Thank you very much.